Okay, hi everyone. My name is Pei, and I'm presenting this paper today, which is perioperative glucocorticoid therapy for patients with adrenal insufficiency, and the dosing is based on pharmacokinetic data. It is done by, I'm sure it's done by a group, but there's only one author here.
Yeah,
And,
if you look at the acknowledgements, he says, I'm grateful to all my fellows, and there must be about 100 of them. So all of them should be authors. This is the way to do papers according to Alex Myras. This is the future. You have one professor of the department as the author, everybody else is an author. They're all just thanked in the acknowledgements.
yeah, there's only one author. And anyway, it was published last year in JCM. Okay, so just to start with a little bit of background. So we know that the activation of the HPA axis is a characteristic response to any physiological or psychological stress. And the intensity of the response usually reflects the degree and duration of the HPA activation. And for a long time, physicians have been told about the importance of adequate glucocorticoid replacement during stress. But we do not know what is the magnitude of replacement that is needed, and that has always been debated upon. The current practice is to give empiric replacement of glucocorticoid to patients with adrenal insufficiency, and that's based on anecdotal case reports published in the 1950s. But what we know now is that since the 1950s, there have been animal studies that show that adrenalectomized monkeys receiving physiological glucocorticoids during cholecystectomy have similar outcomes to those who receive supraphysiological doses. And the stress dosing has variable meaning to different groups of people. And the range of doses that we use range from 100 milligrams to 200 milligrams daily, perioperatively. And we clearly do not know if this empiric dose is excessive and whether it's associated with any adverse effects. And so this forms the background of the research study. And the research question that they are interested in finding out is what is the optimal dose of glucocorticoid needed to prevent a cardiovascular collapse during the perioperative period in patients.
And the other background, Pei, is the paper you discussed a few weeks ago where they gave saline to some people, the Korea paper.
Yes, that is the background, but this is also this one, but
Yes.
they have a slightly different angle here. So they want to know the optimal dose, and what they want to do in this study, to answer the research question is, first of all, they want to determine the perioperative hypothalamic pituitary adrenal alteration in individuals with normal function, meaning normal axis function, and they want to answer the second question, is it based on the data derived from question one, can we develop a protocol which is much more physiological to define, to prevent a cardiovascular collapse in patients with adrenal insufficiency undergoing surgery. So this is looking more on the pharmacokinetics of hydrocortisone tablets that you give perioperatively in, first of all, based on the data in normal individuals, and then taking it to the adrenal insufficient group. So that's the focus of this study, really. So what do they do? So the first thing they do is that they want to know the pharmacokinetics of cortisol. And what they do is that they gave healthy people with high-dose dexamethasone, they suppress them, and they give them a dose of hydrocortisone, and they want to see what's the normal pharmacokinetic response. And based on that, they use that protocol in adrenal insufficient patients to see whether this patient receiving this different dosing, would they have cardiovascular collapse or any adverse effects. So that's their methods. So in the first instance, they take healthy individuals, so 22 healthy people, 12 male, 10 female. The mean age is 36.5. They're not on any medications, BMI 27, and they're giving dexamethasone 1 milligram at 10 p.m. the night before and on the morning of the study day. And then they come to the study lab, and an hour after arrival, they gave them 15 milligrams of hydrocortisone, 6 hours apart. This is one group of patients. And then, actually, all these patients, they give 15 milligrams, and then they give them another time, 25 milligrams of hydrocortisone, 6 hours apart. Each study is 12 hours. And the bloods are taken before they give hydrocortisone, and then and then for 6 hours after it, and then measure the cortisol level every 10 minutes during the first hour to determine the pharmacokinetic profile. And this is what they find. This is in the healthy individuals. And what you can see here is that this is a graph of cortisol versus time. In the first 60 minutes, which is the first 2 hours, taken in the dexamethasone suppressed healthy individuals, following the IV injection of either 15 milligram or 25 milligram hydrocortisone. And the interrupted line is the lower dose, which is a 15 milligram, and the solid line is a 25 milligram. And you can see that the cortisol after they give the dexamethasone was suppressed, at time 0. It's about 41.4 nanomole actually, which means the endogenous cortisol is suppressed by the dexamethasone. Based on this pharmacokinetic data, they determine that if you are given higher dose, you get a higher concentration, and then nadir is also high concentration. There's a fast, rapid disappearance of the cortisol in the first phase, and then followed by a second phase, this phase, which is less rapid. Does that make sense?
Yeah.
Rapid disappearance in the first hour due to tissue distribution at that time. Then this is the graph showing you what happens when they were given 2 doses. So the top graph here is hydrocortisone at 15 milligram at 0 and 6 hours in healthy individuals. And then this is a 25 milligram in healthy individuals And you can see that with the 15 milligram, after the first injection, you get a nadir at about 6.4, and then there's sort of a stacking effect where you're given a second dose, you start with higher cortisol. Same with 25 milligram.
Okay, and the right-hand axis is what we use, and you can see that the levels are sky high. I think that's his point. Even with a small dose of hydrocortisone, the levels are ridiculously high.
Yes, the levels are ridiculously high. That's what they kind of highlighted. So based on this data, they decided that the dose to take forward for the next part of the study will be the 25 milligram, I think, because as you see, the nadir that's reached is about 550. And based on the previous studies that are done, they know that this level is sufficient for anyone to go through a stress response. So that forms us, they decided to use 25 milligram IV, hydrocortisone to be taken forward for the next part of the study. Now, the next part of the study is when they recruited adrenal insufficient patients. So this patient has adrenal insufficiency, and basically they can have primary adrenal insufficiency or secondary adrenal insufficiency. 60 patients are recruited so far, and all these patients were on replacement therapeutic dose of hydrocortisone for over 18 months. If they are primary, they could be receiving fluorocortisone. Mean BMI is usually much higher because of the steroids. They excluded those on oral estrogen because that can increase the cortisol binding globulin, and those who have liver, kidney disease, or hepatitis C. So the next bit of the study is that they schedule this patient, all these 6A patients, they can be scheduled for any surgery. It doesn't have to be adrenal surgery. It can be thoracic surgery, vascular surgery, abdominal surgery, or orthopedic surgery. And all this surgery requires GA for more than 60 minutes. So it's not like a short surgery. They excluded those patients going for CABG bypass surgery because it can cause rapid volume changes on serum cortisol. And for all these patients, they gave in 20 milligram of hydrocortisone on the morning of surgery. That means 2 hours pre-op when they come in. Tablet, yes. Yeah. And this is based on an unpublished observation they've done in the past, where they know that 20 milligram of the cortisol or 20 milligram of the hydrocortisone will give you a cortisol 331 nanomole per liter, which 1 to 4 hours later, and they know that is adequate for any surgery. If the patients have primary adrenal insufficiency, they ask them to continue on fluorocortisone if they're on it. And then when they come in with the surgery, they started them with hydrocortisone 25 milligram IV every 6 hours for 24 hours. That's on the day 0 day, and then followed by, I should write day 0, and followed by 50 milligram every 6 hours for day 1. Day 0 is a day of surgery, basically. Then they take the blood samples, 2, 4, 6, 8, 10, for the first 2 days for the cortisol level. And post-op, that after, if they are on hydrocortisone, they just restarted it. And then if they're on hydrocortisone, they just put them back whatever they are on before. All serum cortisol is measured by direct chemiluminescent instead, and they are analyzed the next day. None of the patients in this group have adverse events. All of them were discharged 1 to 7 days post-op. None of them exhibit any change in electrolytes, and no hypotensive episodes was observed 48 hours post-op. So this is the graph that it came out to. I mean, the axis is a little bit different, but basically, this is a cortisol versus time. And in the first, so when they received 20 milligram of hydrocortisone, their baseline cortisol before the intubation, before the start surgery was 331 or more than 331, and that's adequate. And then they received 25 milligram every 6 hours. It went up to 1,650 or around there, 1,500, and it came back. They received a second dose, and it came to an idea about 700, and then they carry on 15 milligram. So basically, they kept the nadir cortisol about 441 to 938. So overall, the mean cortisol is around 600 throughout the 48 hours. And based on this, they calculate the half-life of cortisol in these two groups of patients, the healthy individuals and the patient with adrenal insufficiency. And what you can see from the table here, obviously, that with the 25 milligram of IV hydrocortisone in the adrenal insufficient people, the cortisol half-life is prolonged compared to the dexamethasone suppressed healthy individuals. It's 3.11 versus 2.02. Okay, and after the second dose, the half-life is even more prolonged. They try to work out the reason why that might be the case. So they work out the volume of distributions. So they calculate the volume distribution in healthy individuals and the patient with adrenal insufficiency with the different doses. And with the lower dose, with the higher, what they work out is that there was an increase in volume distribution with the second injection of for both doses. And it seems like patients with adrenal insufficiency exhibit an increase in volume of distribution, and the clearance of the drugs was actually much reduced after the second dose of 50 milligram hydrocortisone and 25 milligram hydrocortisone. And this clearance is even much more reduced in adrenal insufficiency patients, which all points out to one thing, that in this group of patients who has adrenal insufficiency, there's increased half-life of cortisol after the second dose, which largely could be attributed to the increased volume of distribution. That's the gist of the study. And the main findings basically is that there's a prolongation of cortisol half-life with repeated injections of the hormone, and that there's a progressive rise of the nadir cortisol. And if you keep giving more cortisol, there appears to be a stacking of the cortisol with multiple dosing. And that is even more obvious in adrenal insufficient patients. The nadir cortisol is consistently above 414, which is probably adequate, to cover for the stress response. They could not explain why there's a larger volume of distribution and decreased clearance in people with adrenal insufficiency during perioperative period. Obviously, the limitation of this study is a small number. It's not a weight-based dose, and no one has measured the cortisol binding globally. So the implications of this was really the fact that if there's a stacking effect that's noted, that means we need to really, think about the frequency in which we are administering hydrocortisone. Perhaps we could administer it at every 8 hours instead of 6 hours in the first 24 hours. And this author obviously suggests using a lower dose, because he actually used only 25 milligram. We in period, we use 50 milligram. And sorry?
The normal dose is 100 milligrams. every 6
Yes,
hours.
if you follow the anesthetic guidelines, then they use 100 milligram, which is even higher. The ambient cortisol level that they see is actually similar, and in fact, it's higher in adrenal insufficient patients compared to those with normal HPA axis. So the question that's throwing out there to all of us, endocrinologists and experts, is that is it really necessary to administer excessive steroid to patients with adrenal insufficiency during a stressful surgical procedures? And could we have a more physiological-based regimen of hydrocortisone supplementation for our adrenal insufficiency patient going through stress?
So what's your answer, Pei, to those questions?
Well, based on these studies, it seems like you could have a lower dose. That's what it's suggesting. Of course, this is a small number, you know.
But so I mean, the balance is safety versus risk, isn't it? So if there's a risk with trying to titrate it too carefully, and you run the risk of the occasional patient not getting adequate doses, then it's safer to supplement them with safe doses, because it's only for a couple of days. What's the harm of a couple of days of slightly excess steroids?
But based on this study, you know, even with 25 milligram, you know, you're receiving 500 nanomole of medic cortisol that can titrate, that is adequate for them to go through the risk. I mean, if we give 100 milligram, I would imagine the medic cortisol will be like 1,000 over. I mean, I appreciate that this is safety versus risk, but we don't know what the implications of us giving more steroids. Is it necessary to give more steroids? That's my question. If that is more,
I guess the question, Alex, is anybody benefiting from that mega dose? Or is it really safer to give 100 than 25? And we gave 50, and I remember when we wrote those guidelines.
Yeah, I think a halfway house is a good idea. I guess the only thing theoretically would be, is there an increased risk of infections, or is there a worsening, tissue, what's it called? Healing
Yeah.
processes, but I presume that you need to have several weeks of high cortisol, like in Cushing's, with those sort of problems. But it'd be interesting to see the outcomes of patients who've had different doses of hydrocortisone, the complication rates.
Yeah, the problem is there is no study that look at the implications of these hydrocortisones. No one really have done such a study yet.
Maybe someone should do different doses of hydrocortisone and see the complication rates.
You need a large N. The problem is, the real problem is that none people needed to study to prove something like this. The reason we've just gone with it's safe, let's just give 100, is that it's so difficult to power a study that no one's going to do it.
Yeah.
But as a consequence, as this guy has said, the single author with all his registrars is that it's pointless. He's the first person to even think about generating evidence.
Can I ask, in the graph that was shown, the 25 kilograms seems to be causing a spike.
Yeah, can you go back to the graph?
Why isn't the 15 milligrams causing any spikes at all?
I think it does spike. I think this one is because of the axis. If you look at the healthy one does spike as well.
Measuring. I think on that one they've done 1, 2, 3, 4 measurements in 4 hours, and then they've just done every 6 hours.
So we missed it.
He's showing you the troughs. He's showing you that he doesn't. It's not on the peak. He's saying that the trough is safe.
Yeah, I think he's only interested in showing you the trough, but I think it's the way in which he presented the data. Yeah.
And the other option is an infusion, but that's potentially dangerous.
Well, the infusion is only 2 or 3 milligrams per hour to zero progress. If you use 3 milligrams per hour by IV infusion, you get really high levels. Really high levels. 3 milligrams per hour.
Remember, we discussed the paper in general. We discussed the paper in Journal Club over the last year or so, where they had IV infusions of. They had the 3 different methods. And they were comparing them, and the conclusion was that IV infusion was better. But then we obviously discussed it, said it's not that safe, because if the infusion stops, then by the time they've called the house officer, recannulated, blah blah blah, the patient is going to be cortisol deficient. Whereas a big slug every 6 hours will at least be safer. Yeah.
From what I remember, in that study, the intake was 50 milligrams over 24 hours, so like 2 milligrams per hour. Yeah. And the author was IM50 versus IP50 QDS. Yeah. I do think we are, in general, in every way, using too much steroid. And there's more and more examples of people, they're trying to get evidence, because we're just doing it blind with the statement that it's safe. You've probably seen this new hydrocortisone safety card, steroid card, the red one. And it's being sent into pharmacies. And they want to also give to anybody who's on steroids for anything. If you're on pred for asthma or arthritis, you get a card. And then there's these stories about people who've been admitted with an Addisonian crisis after being on oral pred, which actually it doesn't stack up at all. Really. Just read the cases, right? They're not really crises. They're just kind of headache or tummy ache or vomiting particularly, and presumed crisis. But of course, they get better off with a bit of saline and a bit of steroid. But I don't know if it's steroid doing it because they're already on the steroid. I'm a bit worried that what will happen is we'll give too much steroid like this, and then we continue. And then you measure cortisol and it's low, and then you never stop. So that's the danger of giving too much, even once. But if you measure it and then you don't stop it, that's the strike worry. But these people are already on hydrocortisone, so that's fair enough. It's a good study, isn't it? The only thing is only one author. That's the only downside. Yeah.
He must be one of those sort of musicians who's got like the drum on his back and cymbals on his arms, and then
no, he's not that.
One man band. Cannulas and recruiting and telephone, doing the whole study all in one.
Now, what he's doing, Alex, is he's thanked in the acknowledgements, he's thanked lots of people, but he's not let them be authors, which is a bit mean.
So are you going to cut down the dose?
Well, I think the thing is, we're half what everyone else does. For 2 days, but we could cut to 25. The other thing is, at the moment, when you order the steroids, you click a button, they all come up at 3 days. So if we change it, we need to make a one mega change and decide what else we do.
So here he said something about if your cortisol is over 331, then it's fine. Was that where was I saw that on one of your slides?
Yeah, it's an observational study. This one. So he had a unpublished observational study where he gave people pre-op hydrocortisone 20 milligram, and then they randomized them. I mean, he got one other study that was published in the journal Endocrine in 2017. So what happened is that he put them through giving them DAX and not giving them DAX throughout the surgery, and they found that there is no difference in terms of cortisol response with or without replacement. So he concluded that 331 is probably appropriate.
And so basically what his protocol is to give 1 tablet of hydrocortisone pre-op and then give them 4 injections perioperatively of 25, then 415, and then back to normal.
Yeah, that's his protocol, a much reduced dose.
Our protocol is, for the pituitary ones anyway, is start 50 QDS when they go into theatre for 2 days, and then switch to pred 4 when they're on oral.
We give 50 at a 1 stat dose, and then we give 50 QDS, and then 50 TDS.
Yeah.
But I think in some other places it will be 100.
We've also got the weekend TAR place, haven't we? Because they have their surgery on Thursdays. So you want to play it safe on the weekend. You don't want to start messing around too much.
Well, what we do at the weekend, they're all on pred now. So basically, they're on hydrocortisone on Thursday and Friday.
Oh.
Saturday morning, they get pred 4.
They go 10.
No, sorry, pred 10. Sunday, pred 4. And they have cortisol pre-pred. There's one other confounder that we haven't talked about, and that is in some, but not all of the patients, the anaesthetists give 6.6 milligrams of dexamethasone on induction of anesthesia, which I discovered in the drug chart. And I dug around. There's some very nice data in the anesthetic literature that says if you give dex 6.6, there is much less post-operative nausea and vomiting in recovery. And it's a blind randomized, it's a good study. The anaesthetist randomized patients to saline or IV dexamethasone blind and showed a significant difference in outcomes from their point of view, which is getting out of recovery. So I think it'd be hard to stop that practice. But they don't all do it, interestingly.
Or do you give the pan of bread?
It's a good question. You don't, what do we give? It's kind of a double dose, we thought. But maybe we don't need to.
Maybe you need to go to 34.
Okay, I'm game for that. In fact, I'm game for strict. If we're going to change, we should do the whole thing in one go. So what do you think, everybody? Let's ask Alex, who's obviously gonna.
Well, whether we should go down to 25.
25. Well, he's done 25 on one day and 15 on the second. I don't know how difficult that is to draw up. Is that because the bar's 100, isn't it?
So even 20 would probably be okay.
It will. Looking at that graph, 20 would be okay, wouldn't it? Yeah, because 25 is majorly over the top. In fact, 15 would be okay. If we give them,
But yeah, dilutionally might be problematic. So
if they're very obese or something.
oh no, I mean to the dose, calculate the
Oh,
dose.
I see.
Well, 20 is increase of the 100 milligrams.
Why was the numbers in this study? Oh, they were small.
The numbers in the study is small. I mean,
It was between 20 and 68 in the second part. So 20 healthy volunteers-ish, and then 68 patients.
yeah, 68 adrenal insufficiency and 22 healthy.
So did they run into any problems at all? With
No.
any patients?
So none of them have any, they were all discharged within 7 days, no electrolyte problems and no cardiovascular hypotension and anything that I worry about. Oh, that's what they say.
I mean, I do think it's quite good to get evidence of what we do and then find that what we do is wrong.
Yeah, should we check our patients' cortisol levels before we give each hydrocortisone dose on day 1 and day 2, and prove that are we giving too much of hydrocortisone in our patients? Then adopting this one will be a good.
We look at the levels of
Yeah, our
okay,
ones.
the top levels. We know it's going to be high, don't we? 100 is right.
Yeah.
The problem we have, right, is the BNF says very clearly you must give 100 milligrams, okay? And part of it is the pharmacologists say the same. And when we were writing exam questions with the undergraduates, and when we said 50 milligrams, they said that's wrong. That's the wrong answer. The right answer is 100 milligrams.
Really?
Yeah.
The anesthetic society say 100 milligram. In fact, they give even higher doses, I think.
Mm. So we've got an uphill struggle.
The question is, what is there to gain by reducing the dose of steroids for 2 days?
Well, you don't
Yeah.
know if they might also get hyperglycemia. Don't know what.
There you go. Hyperglycemia.
Yeah, okay, fair enough.
That's one good reason.
But you could just check people's BMs versus what have you got to lose? Well, you could end up with a bit of a disaster.
You can't. You can't get a disaster because this paper is proving it's not going to be a disaster. That's the difference. I mean, I agree it could have been, but now we've got good evidence here.
I guess if this is adrenal patients, they haven't got their mineralocorticoid function either, whereas the pituitary patients do. So it would be even safer to do this in the pituitary patients.
So this study includes the adrenal insufficient one.
Yes, it's not pituitary.
Fludro. So what he's put, I guess, in this study, there's enough hydrocortisone here to cover the aldosterone axis. It's like 600. That the trough cortisol.
So were they not taking Fludro throughout?
So there are people with central adrenal, primary adrenal insufficiency. So they were at least, I think some of them have primary. I think 5 men and 8 women have primary adrenal insufficiency, and they are on fludrocortisone. So with the fludrocortisone group, those who are taking fludrocortisone, they just ask them to continue their fludrocortisone.
So they took it what on the night before?
They
the
understand.
operation?
So before they come into the operation, they give 20 milligram hydrocortisone, and if they're on whatever fludrocortisone they are taking, they just take it.
So they take an oral tablet before
And
the
then-
operation.
Oral tablet. That's it. Yeah.
Okay.
And then they go for the operation, and then they give them hydrocortisone IV 25 milligram every 6 hourly on day 0 and 15 milligram every 6 hourly. day
So-
one, and then they put them.
So it's the Hydrocortisone that's really keeping them away from complications, isn't it?
Yes, yes, that's certainly possible.
So,
Well, I know that, I bet you that if you did a study with whatever they were on
Yeah,
before surgery,
yeah.
no increases, the same amount,
No, no steroid at all parenterally. You'll be all right.
you'd probably be fine.
So there's two questions. There's one from Mohsin who was told off by the nurses for giving less than 100 milligrams because the vial contains 100, and then Ambry is 600 enough. In septic patients, well, the up to 1,000 was what we believe, but I think there's a paper from Tricia about surgery. There's a few papers around that have lower levels. But you're right. If there is no gain to reduction, then we don't change anything necessarily.
Yeah, but you will never be able to get that answer from the study.
No, okay. Shall we check the blood sugar? We don't, do we? The blood sugars on our patients to see if they're higher and whether that might be a reason.
I think what you should do is if you go down the dose and you find that there is no adverse outcomes,
Yeah,
that's a good thing.
yeah.
Probably.
I agree. I think probably it's a good thing. There are problems because of the belief that it's good to be on 100, and then the fact that glycogen bars are 100. Just you can throw half away.
Well, it's
Yeah.
a waste, not a problem.
No, it's just that they've got to draw it up. You either add the whole bar and give it, or you carefully measure a small amount. Okay. Anyone else? This is my thoughts from who's else is around. What does Ali think? DJ.
I can tell you that I think it's unnecessarily complicated to start changing this regime, because this regime doesn't do any harm to people and it just keeps them safe. If they vomit up their fludrocortisone, at least they've got enough hydrocortisone on board to give them mineralocorticoid activity, enough activity, and also, or cover rather. And also, in the morning after their operation, they're going to feel sick and they probably won't take their fludrocortisone when they've got primary adrenal insufficiency. So personally, I think this is unnecessary fiddling for something that actually keeps them safe and doesn't actually do them any harm, really. I mean, we know it doesn't do them any harm, short-term high-dose steroids.
Yeah.
One day of high-dose steroids is not going to do them any harm, and it's going to keep them safe, especially in people who have primary adrenal insufficiency.
Yeah.
Personally, I think it's unnecessary fiddling, and it's going to change. It'll end up being a problem because it's trying to make something more complicated than it needs to be. We just need to keep our patients safe.
Yeah, I do like the simplicity of having a fixed dose for the whole time. I must agree.
Exactly. So that's I think this is. I think it's good to see that what levels people are getting when you give doses, because that's good for when you've got people on the wards and you're giving them extra hydrocortisone because they're septic. And we know that we don't have to give 100 QDS or 50 QDS, and probably 20 QDS is perfectly adequate, and perhaps even less. So it's useful to get this data for other situations. But I think in the post-operative situation, anesthetic situation, I think it's better just to stick with what everybody knows and make sure that it's never missed out.
Yeah.
Once you start rationalizing regimes for different scenarios, you then invariably are going to end up with disasters.
Yeah, that is true. It is possible that people will get confused because it's easy to have one dose, isn't it? I will say to you that at the moment the protocol here is 50 QDS. And
oh yes, well yeah, 50 QDS. So yeah, well that's still 200 a day, which covers them that gives them mineralocorticoid cover if they are vomiting up their fludrocortisone. Because it's those people you're sort of a bit worried about when you're, when you don't give them enough hydrocortisone.
Yeah. Okay.
And it's.
So we don't need to. I can see that what we've got is half what a lot of other people use. The 25-15 thing is complicated.
But
I agree with that.
Using 20, 25, 15, just keep them at 20. So you just go from 50 to 20 plus. We give them 50 now. How do we really know that we're not causing any harm? Do we really know that it is not causing a problem?
It's only 1 or 2 days. I mean, we know that in the long term, too much steroid is definitely bad. But The only risk is if they fail a test because they're on too much steroid, and then you rerun it. That doesn't apply to primary cancer.
But surely if a normal healthy patient undergoes surgery, what
Yes.
do their levels go up to?
Well, that's Trish's paper, and there's a very wide variance, but it's not as high as we thought.
Yeah, so
It's
why do
like
it
this.
makes intuitive sense
Yes.
to try and mimic that?
Yes. I think we need to, if we're going to make a change, we need everyone to change. I don't think we should just do it by ourselves. Yeah, as a national thing.
Never.
No, because nationally everybody's 100. I mean, we're half as much as everybody else.
Maybe they are doing something wrong.
Maybe something wrong. Okay.
We'll be the first one to
Thank you,
try.
Pei. That was very. Oh, at what cord effect do you get the anabolic effect? It's when you saturate 11-HSD on the aldo receptor. So it's at about 500 nanovolts on one of the applications that I found looking at the receptor. So what happens? You know how the kidney's got 11-HSD that deactivates cortisol on the aldo receptor. So if you go above a certain level, you saturate the enzyme, and so you then start having aldohydride-like activity. So it's at that level 500. And it's possible that we evolve this mechanism of having a blast in ACTH kind of stress so that you switch on both receptors. Yeah, I mean, why do you have that? Why is that system in position? I don't know. But one possible reason is that when you're really under acute stress, I mean, hemorrhagic stress usually, you make low ACTH, and that will have some aldo-like activity when it's really, really high. Maybe that's a survival advantage. And it's food for thought. I'm keen if we can avoid steroids in general to minimize the dose. The other paper that Pei had was giving saline instead of hydrocortisone, which was just as good.
Yeah, I had it here, Prof. I mean, just
Yeah. Bijal, what is the data for IM versus IV? So there's a paper that we discussed last year that compared them.
It was Vibka, wasn't it? Vibka Art.
Quite right. And the conclusion was IV
Yeah.
was better. The infusion was the one that won. The IV boluses, IM boluses, and subcut boluses were all the same. There were 4 arms to that study.
Yes, that was
The IV. Go on.
Sorry, now I was just going to say that I remember us saying how, because we've all, in the books where it says give IM hydrocortisone, but actually it's not, doesn't last that much longer than IV in actual fact. So IV, that was sort of reassuring to carry on with IV 4 times a day.
Yes. So IV, they gave 50 QDS, and it was either IV, IM, or subcut, and all 3 were very similar. The IV went down a bit more quickly, but it still it didn't get down to too low a level. So as it says in all the books, you can give IV or IM, and now also subcut. Although I think the file just says you can't give it subcut. Is that right? Some of them say IV or IM use. The licensing perspective. Any other?
There's a good, I think there's a paper that I saw in JES this month that talks about different cutoffs for short synaptin tests. So it might be worth, seeing as we enjoy a steroid theme in Journal Club. I don't know if someone wants to do that one week.
Do you want to send me that paper? Well, I think I've seen it actually. There's quite a lot of papers coming out on the harms of steroids. There's another one in PLOS One that Bernard sent me yesterday. That's really quite interesting, and it basically says that if you're on between 5 and 25 of bread, that you basically have vascular disease in time. So in other words, 5 is too much. This is data as opposed to me just making it up. So have you got that paper, Alex?
Yeah, I'll find it and I'll email it to you, Bijal.
Send Bijal, and she can tell what we're doing in the next few weeks. That'll be a good one to cover too. Thank you all.
Thank you.
Thank you, Pei. Well done.
Thank you. Yeah, very.